Sutures can be a complete and utter mystery to everybody, and sometimes they're like that for me. What we have here, the company we're using is Covidian, but the majority of places that you'll work in will use Ethicon sutures, but predominantly they do the same thing. So I'm going to use what I call old and new currency, the old type, because you'll get confused if people say Proline and SurgiPro, so I'm going to give you both versions. If you look at the colours, we'll just quickly go through what they are. The mauve boxes, it says a polysorb, otherwise known as Vicryl by Ethicon. SurgiPro is your Proline. PDS is your Maxon, which is the silver box here. Soft silk is your black silk. And nylon is your monosoft. Okay, so that gives you an overview of what you're looking for. And now let's look at what they actually do. Right, polysorb, otherwise known as Vicryl, will actually dissolve in about sort of 2 to 3 weeks. And if you look here, for the Vicryl repeat even quicker, a week to 10 days.
Absorbable stitches such as this polysorb or Vicryl stitch are used for many cases of blood vessel ligation and transfixion, and these will eventually degrade within the body tissues, but because of their braided nature they hold very well, and again you only need to put on 3 throws, occasionally 4, in order to be secure of your knot.
Black silk, often used for a common suture here, if you can see it's got a straight needle, is to secure the drains.
This is an absolutely non-absorbable stitch. This is silk and it is braided and it is very secure. It snugs very easily. You don't need to use any slip throws or slip knots with this. They should remain secure because of the amount of grip available because of its braided nature. One of the complications of braided sutures, however, is that they are more prone to infection than monofilament sutures, and they don't glide through the tissues as easily.
So your Proline is non-absorbable, and it's used, this suture, I'm funny enough telling you, it's double-ended, can be used on aortas actually, but most commonly with one needle would be used perhaps for a purse string on an anterior bowel resection, so it's non-absorbable. That's the Ethicon version, and then you're looking at the Covidian version.
Non-absorbable monofilament sutures, such as this SurgiPro or Proline, are usually used for vascular anastomoses. These glide through the tissues very nicely, and they do require a number of slip knot throws in order to make a secure knot once you've completed your anastomosis. Because they are monofilament, the chances of infection are much reduced with these.
And then we have the Maxon, often used for mass closures. What we have here is monocrol, and this is a suture our breast surgeon would use. It's monofilament, and there's less risk of infection using this suture.
Capricin, or monocryl, to give it its other usual common name, is a monofilament absorbable stitch that is usually used in the subcuticular layer of the tissues of the skin. This glides through the tissues of the skin very nicely and is absorbed readily within 2 weeks of insertion.
Right, monosoft nylon can be used for skin. As you can see, I'm showing you that straight needle, and there's a curved version. Again, we talked about the common sutures. This is the monosoft is a 3/0. As you look across the stack here, you're seeing various numbers, 2/0, 0, 1. Let's look. Once you see the 0, 0, 3, 0, we're looking at very fine suture. The finest I have in this rack is a 5/0. Okay, very, very fine. And if you go into the eye theatres, it can be up to a 10/0. So when you start to go down, so you start to count down 5/0, 4/0, 3/0, getting a little bit thicker now, and then you start coming to your 2/0s, and then you start coming to your 0, which is up here. This would be used on a hemorrhoidectomy, for example, the one I'm showing you now. So you're looking at getting a little bit thicker. 1s, and pretty well that's it where we stop. A few years ago it used to go up to a 2, but you'll find the suture materials now are such good quality that actually you don't need that extra strength. You'll find that these have gone through rigid testing, but the number 1 is where we stop here. We're looking at sutures and sewing people together, but actually more commonly we're finding people are using Dermabond, skin glue. Fantastic stuff, very expensive mind you, this is about £30 an ampule. But very, very effective. So for example, if you're doing some paediatrics perhaps, you're doing laparoscopic where you've got, you put the port sites in, you basically squeeze, and it's a glass double layer ampule, you just crush it, you squeeze the Dermabond down into the foam, and with those wonderful gillies that we talked about, you pinch the skin edges together and you would run that sponge along the skin edge, you'd wait for it to dry, and then you take your forceps away, and believe me, it's very, very effective. So that's another form of skin closure, but without using needles. I'm showing you a range of blade sizes here. Let's go logically. You've got a 10, 11, 15, and that's pretty well what we stock in this hospital. A 10 blade, most commonly used in general surgery. Even if you're doing that very large midline incision, you'd still use a 10 blade. Moving on to an 11 blade, very, very pointed. Use with care. May be used for a sphincterotomy, but very, very pointed. Treat with care. 15 blade, nice sort of round edge. If you look, it's got a nice round edge there. Be used for the smaller, the very tiny skin lesions perhaps, you know, you've got a mole that needs removing. Again, if you're working with a longer barred parkers, perhaps when we looked at the upper GI work, that would be the blade that you'd use internally. The 21s and 22s we're stocking in here, but really you'd find those perhaps when I showed you the barred parkers and orthopaedics. They're much bigger blades. I've got one here to show you. You can see the size of them. On general, these tend to be the 3 that we use, and that would perhaps be orthopaedics and gynae. So we talked about skin closure, and just sometimes the wound may need extra support. So what I'm showing you here are Steri-strips. They're sort of paper, sticky, sterile strips. There's all different colours and sizes that you can use. So you can see them here. So many people would cut them in half. How you could support the wound by laying them across, or some just like to lay them straight down the incision site itself. Next to the Steri-strips, I'm showing you a cellulose Surgicel as a hemostat. Really important that you have that available, certainly if you're working in liver beds and you've taken a gallbladder out, and you can use it laparoscopically. It can be popped down a port, but on open surgery it's very effective as well. We do have other things if the patient, this doesn't work, but you're going a next stage up, and that's on this site, Tacoseal or Flow-Seal, which is a human fibrin and thrombin, and it's basically a foam, but we have them in the cupboards outside. But be aware, it doesn't just stop there for your support. You have other things in your cupboards. Make yourself aware of what the hospital is stocking to help you, and there are guides to take you through how to mix that up. But please be aware of what's out there. But once you start going on to the Tacoseal and the Flow-Seal, remember that that's human, so you need to keep the stickers. Be aware that your patient may be a Jehovah's Witness, and you must keep a record of, there are stickers that come with those particular products. You won't need them for this, but you certainly will need them for those other 2 products. What I'm showing you here are the skin preps that we use in this theatre, and if you look, we have a lovely pink solution here, and that is alcoholic solution. Very effective, but you wouldn't want it to be pooled, because if you're using electrodiathermy, this is alcohol, it's inflammable, so be very careful of that. So any pooling, not advisable, but a great skin preparation. One quick disadvantage is, of course, you can't see where you've prepped, and I have only one surgeon that uses this. This is the same thing, but we put a dye in it, and I'm not making it up because it only lasts 7 days, but I would add that dye and that would become really, really vibrantly pink, and it would last 7 days, and you could clearly see where you've prepped, and that's again an alcoholic skin preparation. But remember, no pooling, particularly around the umbilicus, where of course if you were doing an umbilical hernia, you know you've got a little pooling, you'll end up having a fire. And particularly with all using disposable draping, I think majority of hospitals now use diathermy drapes. So you have to be very, very mindful that you could have a burn, and that goes back to the diathermy forceps, that you always make sure they're placed into a quiver, that plastic tube you may have seen on the trolleys, that the diathermy forceps, if you stand on the pedal, you could create a burn to the patient. So that, now we're moving on to the aqueous. Again, just going back, you wouldn't use those in the abdominal cavity. Now this, again, I'm always going to refer to my younger surgeons. We talked about handheld diathermies. This seems to be the most popular choice of skin preparation, and that's bethadine aqueous. I know it says Vidine, but it's basically bethadine aqueous, iodine in other words. Again, you can use that internally. We'd use that perhaps in gynae to do a high vaginal mop. You could make it up and you could wipe over the bowel once you've resected it. We showed you those clamps, so you could put a swab and clean around before you anastomose. You could use it watered down, as we often do when we do a rectal washout. If you've got someone that's had peritonitis, you could make up a jug with some saline, and you put whatever the surgeon wants, how many mils, and it's very, very effective. You can get alcoholic. We do use it in orthopaedic theatres, but we do not use it in the general theatres, but be aware it's used in orthopaedics. Well, we're just looking at little solutions here. Let's look at here. This little bottle is Fred, commonly known as an anti-fog that you'd use in laparoscopic surgery. Next we have here Bonnie's Blue. This would be used for skin marking. We showed you the breast oncology set, and there's a little marker pen, and it's very effective. A lot of plastic surgeons like to use this rather than a disposable. So that's Bonnie's Blue. Here we've got a mixture of paraffin and glycerin, all used for the same thing. And basically, if you're using, we showed you Vicryl and Polysorb, and it's braided, and it can be quite difficult to get through the tissue. So just by running that nice oily paraffin or glycerol down through the suture, it glides through the tissue so much easier. Certainly when you're using a bowel anastomosis. A really good idea, just if you notice that the suture's tugging slightly, just offer that to your surgeon and it will glide through. We talked about the oily phenol. That's the only one that I would keep here. It's on prescription only, the liquefied phenol. So now in this hospital, an alert went out and it clearly stated that that must be not mixed. It needs to be on prescription only, and that is only in the last year. And that's always been my complete and utter nightmare, that those two should be mixed up. It was about 10-15 years ago, I walked into a clean room when I knew the surgeon was going to be performing injection of hemorrhoids, and it's got a beautiful almondy smell, it's very distinct, and I questioned the scrub nurse, have you drawn up your liquid phenol? And she said yes, oily phenol. And when I looked at it, she'd actually drawn up liquefied phenol. And can you imagine how disastrous that would have been if that was injected into the patient's bottom if the surgeon hadn't checked. So there's lots of things that you'll find are out on these shelves. So it goes back to you checking, double checking. Look what your nurse is giving you. Never ever trust anybody. Benzene compound. Great when you've raised a stoma and you're trying to, not great that the stoma's been raised, but great that you've got something that's going to get that stoma bag to really stick. A very small amount of that, just dabbed only on the skin around the stoma, not near the stoma. That bag will really fit so much better. Showing you Proflavin. Perhaps not so commonly used. It's not an ideal choice. Often used for packing abscesses, but with the advances of Aquacel, particularly Aquacel Silver, we would encourage our surgeons to use Aquacel, because once you soak Proflavin into a gauze roll and it's into an abscess, ex-abscess site, it's very hard to remove the next day, and very, very painful for the patients, whereas Aquacel slides out so much easier. When we were doing our little demonstration on electrosurgery diathermy, we talked on Explume. Now, all hospitals should be displaying this chart. Please take the time to read the chart, and really gives you a good insight to how damaging Explume can be for you and your co-workers. So again, this is issued by the Association for Perioperative Practitioners, which is the guidelines for all theatre practitioners. Well worth having displayed in your theatres, and if not, you can always access a copy of it from the AFPP website. I've just shown you the chart that was produced by the AFPP on Explume, but this is another gold standard. This is the swabs, needles and instrument managing the risk. Again, please take the time to read this. It looks like War and Peace, I know, but it's well worth it. I personally went through an experience. I was scrubbed with a very senior surgeon and a swab couldn't be found. We didn't close the patient. Several times we looked for the swab. I had a reasonable idea where it was. It was actually tucked up by the spleen, but the surgeon requested for the C-arm to come into theatre. But if you read your War and Peace, it clearly states that actually a C-arm probably isn't strong enough to pick up the X-ray detectable strip, which I'm about to show you. It will probably not pick that up. Now that was discovered by the radiographers using the C-arm in theatres. A swab somehow got underneath a few years ago, not on this site, and they realised that it actually hadn't picked up the X-ray detectable strip. So now it's recommended, if you're mislaid a swab, please remember you request for an X-ray, not a C-arm. But it's well worth a read. It talks about if you have a CPOD 1 that comes to theatre, and we all know they're limb and life threatening, there could be a bleeding patient hemorrhaging, perhaps maybe there wasn't enough time to check the sets. It talks you through what you should do. But definitely worth having a jolly good read on that.